Okay, so you'll see some faces and some names on your screen, and I'm just going to go ahead and start introducing our speakers and our panelists. So up first is LaKendria Ross. She's a native of Houston, Texas, and who has worked in Relocation Services Department since 2016. She received her bachelor's in psychology from Fisk University in Nashville, and her public health certification from the University of Texas Health Science Center at Houston. She enjoys advocating for the disability community and ensuring that they are exposed to useful resources. So start thinking of your questions for our panel for LaKendria. I know a lot of us would love to have the ear of a relocation services specialist, and this is our chance. Lydia Nunez is Landry is a disabled activist, an independent scholar specializing in disability theory and deinstitutionalization. Lydia has a degree in social work, but has reformed that knowledge to work in a liberatory framework, applying it to her activism with several disability justice groups as an organizer with the Gulf Coast chapter of ADAPT, a member of the National ADAPT, Not Dead Yet, and the National and Texas Gray Panthers. Currently, she's working on a chapter for Routledge Bioethics textbook to educate healthcare professionals about disability justice, and she also contributes to an economics blog dealing with healthcare reform. And Lydia didn't put, but in addition to all that, she's also a wonderful volunteer ombudsman in the Harris County program. So she brings a very important and unique perspective as a volunteer ombudsman as well. I'm hearing a little echo, so I bet somebody in my state office will go ahead and mute everybody. Great. So Bob Kafka has been a disability rights activist for 45 years. He's the co-director on the Institute for Disability Access, organizer of Adaptive Texas, coordinator for RevUp Texas, and has a master's in special in education from the University of Houston. Kathy Robles Cranston has worked for over 40 years as a community attendant. She's an organizer for Adaptive Texas and co-creator of Personal Attendant Coalition of Texas, also known as PACT, and a national organizer and co-chair of the National Adapt Attendant Workforce Work Group. She works to bring mutual dignity and respect between the community attendant workforce and those served in home and community-based service programs, as well as fighting for just wages and benefits for these workers in order to meet the needs of those served. Josue Rodriguez, from El Paso, Texas. He's a local, state, and national organizer and an activist with ADAPT. He first got involved with disability-related advocacy while in college. He has mentored youth with disabilities through his involvement in programs such as Peer-to-Peer, the local and state youth leadership forum, and the ADAPT Youth Summit. He's a former community organizer for the Memphis Center for Independent Living. Through his work through the MCIL, he's helped organize community groups such as the Memphis Bus Riders Union and the Latinos United for Children's Educational Services. Through his community involvement, he was able to bring awareness of accessibility issues and the interrelatedness of disability rights with other social justice movements. He currently lives in El Paso, Texas, where he's an organizer with El Paso Desert Adapt and serves as president for Grupo Dignidad, Igualdad, Oportunidad. He also serves as a board member for the Accessibility Advisory Board for the City of El Paso. Stephanie Thomas is co-director for the Institute for Disability Access, a founder of Adaptive Texas and member of PACT. She's worked for 3 centers for independent living, and she's organized ADAPT's VISTA program to transition people with disabilities from nursing homes to the community. Last but not least, Nancy Crowther earned her BSW from the UT Austin. Her career began as a VISTA volunteer with the Coalition of Texans with Disabilities and staged the Independent Living Center in Austin. Her work and passion, it was working to teach independent living skills to transition to the community from nursing homes and the local state-supported living compound. Having met Bob Kafka and Stephanie Thomas, Nancy's passion blossomed into accessible transportation and fighting alongside ADAPT to make Austin's Cap Metro the first major transportation authority in Texas to be 100% lift equipped. After a 25-year career with Capital Metro, Nancy retired and dove back into community organizing with ADAPT and the Personal Attendant Coalition of Texas to continue the passion of community living for all. So obviously, wonderful and important experience here. And I'm going to stop talking and pass it on to them once I show my screen. And Lydia, you are muted.
Okay, can you hear me now?
Yes, we can.
Okay, sorry about that. I unmuted and someone else, and so it remuted. So our goal here today is to help put your ombudsman work in the context of disability rights. It may not be obvious to you how your work connects to disability rights. Most people believe that nursing homes are not only the practical solution for older and disabled people who need assistance, but the natural solution. They think, what else can we do? Who'll care for people if their families can't? They think nursing homes are the only option. We want to show you that this isn't true, that there are alternatives already available. These options allow people to live the lives they want to live in their own communities and not the regimented lives of institutions. And they're cheaper than institutions. Sorry, go to the next slide, please. I guess you can go to the next one too after this. Go ahead. Thanks. Disability rights is exactly that. Like civil rights generally, it's about ensuring that people with disabilities can lead self-directed lives in their own homes and communities just like everyone else. Next slide, please. The common belief about disability I just mentioned is based on what is called the medical model of disability. On this model, disability is solely a matter of dysfunctional biological systems, and so any obstacles disabled people counter in our lives, getting around, getting jobs, and so on, are entirely due to our bodily impairments. Therefore, our problems reduce to the medical domain, and only healthcare experts can provide solutions. Next slide. Disability rights activists and disability scholars disagree. We endorse the social model of disability. This model understands that how social spaces are arranged, how buildings and so forth are designed, these things in themselves are disabling. It also recognizes that our social arrangements are not accidental. Ramps are easier to build than stairs, so why did it take the American with Disabilities Act to get stores, office buildings, and schools to start building ramps? It's because social practices, representations, and attitudes toward disabled people have resulted in stigmatizing prejudice, discrimination, and paternalism. And most relevant to this talk, they resulted in the forced social exclusion and institutionalization of disabled people. The point is this: how the lives of disabled people are going, what obstacles stand in the way of our living the lives we want to live and where we want to live them, is solely a matter of our bodies. Social structures and attitudes have blocked us from jobs and educational opportunities and made it natural to institutionalize us. An ombudsman can help change this. And thank you. And at the end of our PowerPoint, after all of this, there's an addendum with more information. And so I think the next person to go can go ahead and take it. Next slide, please.
So who are we? Adaptive Texas is a grassroots disability rights organization. We were formed in 1985, and we started with the fight to get lifts on buses. We will ride. Our advocacy started with that, and then it led us to the 1990 passage of the Americans with Disabilities Act. And after we were able to accomplish that, we also turned our focuses onto the main focus, which was community attendant services, freeing our people. Next slide, please. Next slide, please. And so with that, you know, we've covered so many different issues through the years. And we went from lifts to our homes, not nursing homes, which has been our mainstay the last few years, several years, I should say. You know, along with that, we've tackled so many other issues like affordable, accessible housing, attendant services, better wages and benefits for our community attendants, as well as many other issues. And all of these issues allow people with disabilities to live independently in our community. Next slide, please. So in our next slide, you're going to be seeing 3 or 4 different photos. And I'm going to wait for the next slide. Okay, great. So in my upper left-hand corner, you will see there are several people with disabilities at the forefront, one of them carrying a sign, "We shall overcome." This took place on the March on Washington. This was in March 10th of 1990. Stephanie Thomas is in a wheelchair and she's holding a sign. It says, "Access is a civil rights." And to her left is a gentleman named Frank Lozano with his dog named Frazier, his guide dog. And then to his left is Jennifer, a young person that was involved in our movement. And this was the March on Washington. There were 1,000 people with disabilities that had united from across the country, and they marched from the White House to the Capitol. And this is one of the many actions that eventually led to the passage of the Americans with Disabilities Act, our civil rights law. And then the next picture at the top across that took place in, I believe, Las Vegas. And the gentleman to the far left, his name is James Templeton. And James came out of an institution after living in an institution, I think it was for over 30 years or more. And the lady in the back that has the sign attached to her back in the middle of that photo, it says ACA is for cell. Basically, it's the death camp. ACA stands for the American Home Care Association, and they're the largest lobbyists that advocate for nursing homes, what they call nursing homes, but they're institutions and death camps in our eyes. And the gentleman holding the flag, that was Bill Scarborough, a longtime member of our organization who has since passed away, as well as James. And at the bottom of those 2 photos is our wonderful organization that is led by Lydia Nunez. That is located in Houston, and then Shemaine Barrow is there also holding the sign. And actually they are in front of a large grocery chain. And where should they have placed those Christmas trees but in the accessible parking spots? And so they are out there protesting against that, because we fought long and hard for this law to be put in place. And that shouldn't happen, not now at all. So, in a couple of weeks, we will be celebrating the Americans with Disabilities anniversary, the 31st anniversary. And so with that, I will end my presentation. Disability rights are civil rights. People power, help change happen. Thank you. Next slide.
And just a quick note, everybody, I'm changing the slides, but it seems like there's a little bit of a delay. So feel free to get started and feel confident that it'll be coming up.
There it goes. Can you hear me now?
Ma'am.
I feel like a commercial. Can you hear me now? Alongside the Americans with Disabilities Act was an important decision that came across through the Supreme Court system. It appeared as the people were becoming more independent and moving out into the community with the help that was out there and the services that were out there, that some people who were stuck in segregated institutions, possibly with severe disabilities, were not given the opportunity to move out into the communities. This was bad because it's like holding a person against their will or into a prison. And that's what a lot of the institutions come across as. Well, on June 22nd, 1999, the Supreme Court held in Olmsted versus LC, and LC is the initials for one of the claimants, that the unjustified segregation of people with disabilities constitutes discrimination in violation of Title II of the Americans with Disabilities Act. What that means is that people with disabilities have every right to live where they want to, and they have the choices that everybody else has. And there shall not be any barriers to those decisions or acts. And they stated, the Supreme Court also stated that placing people who can handle the benefits of the community, and I'm going to give a small case in point, people that can take care of things and can live out in the community need to be out there. But for some reason, as Lydia mentioned earlier, nursing homes or institutions seem to be the go-to for people with disabilities by places like hospitals and such that really don't know what to do with people with disabilities. They don't talk to them. They don't find out really what's going on. But my institutionalized issues that are worrisome right now and still is that we're having a situation where we're not finding the attendance we need in the community to help keep us independent and to keep us in our homes and to keep us active in our community. 2 reasons. One, the salaries are, okay, are y'all sitting down? $8.11 is the entry for attendance. I'm sorry, Dairy Queen just beat out my attendant by giving $15 and $16 an hour. So we're not getting the number of people we used to have out in the community doing community attendant services, and that's why Kathy and I work so well together, is because we understand both from the consumer perspective and from the attendant perspectives what the impact is. So the Olmsted decision said you should be able to live life in the community, have life activities just like everybody else. And there shouldn't be anything that should force you into an institution that you, the person with the disability, don't want and are not able to live in. So Olmsted decision helps to guide a lot of our programs, in so much that you may hear Olmsted decision because that's the Supreme Court side of our independence movement. So thou shalt live in the community. So that's your introduction to Olmsted. Next.
I'm Bob Kafka, and one thing I just wanted to start my presentation. Sometimes when we talk about disability rights, people sort of think of younger people rather than older people, and there's this distinct definitional disability and aging, disability and seniors. And I just want to convey, for years, I used to say people with disabilities of all ages, but I got beaten up by y'all, some of the senior advocates and aging advocates. So it's now people with disabilities and seniors or older people. And I have personally an identity problem because I'm 75 years old. And I'm also, I've been a quadriplegic close to 50 years. So I don't know how definitionally I stand. But the bottom, the bottom line though is that, you know, when we're talking about all these issues, we're talking about people with disabilities regardless of when the age of onset, because, you know, the silos are so distinct in terms of people with developmental, mental health, but, you know, and we contend that you don't go into a nursing home because you're old, even though the vast majority of people who are in nursing homes are older. The reason you go into is because you have a disability. So I just wanted to make that in terms of that. And the slide you're looking at, the Medicaid institutional bias, is really the reason it's there right after the Olmstead is because that is one of the reasons that the case of, you know, Olmstead versus Lois Curtis and Elaine Wilson came about, was there because since 1965, Medicaid has had an institutional bias where states have to provide nursing home as an entitlement. And even today, 55 years later, it is still the entitlement only to the nursing home, and all home and community-based services are optional. And so the one of the things ADAPT has been fighting post our fight to get access to transportation has been the Medicaid institutional bias. And it has really been amazing to us how difficult that has been, considering that when you ask anybody, you know, they prefer home and community-based services over institution. And we contend, especially today with all medical technology, that every person with the right support package can live in the community. And so, but the reality is we are still under the Medicaid institutional bias. And even after the Olmstead decision, which there's been, you know, great gains since then. So the next slide, please. Money following the person. I know that in your training that you've had information about money following the person. You may not know, though, that money following the person started here, and Texas has been actually a leader in the getting people out of institutions. Texas doesn't lead a lot in terms of human health and human services. And we actually won an award. I can't remember what year it was in terms of that, because of the actually excellent work that the Health and Human Services Commission did post the Olmstead decision. It created a cross-disability, cross-agency committee to basically try to get and keep people out of nursing facilities and other institutions. We're primarily talking about nursing facilities, but the Olmstead decision cross-cut all populations. And because sometimes when people look at it, the two women that Lois Curtis and Elaine Wilson both had developmental and mental health issues, but the case, it cross-cuts all disabilities. So if you're a person who is 80 with a disability that wants to get out of a nursing facility or wants to stay out, and because of various different things may be forced into an institution. So real
many older people have gotten out.
Yeah, I mean, I think it's something like over 100,000, maybe 150,000 people have gotten out across the country since the Olmsted decision. And to a large degree, that number would be larger if funding was there. One of the funding aspects is money following the person. Where it came from is very interesting. After the Olmsted decision, the state of Texas basically believed that, how are we going to do this? It's going to really bust our budget. And Representative Glenn Maxey, who's no longer in the House of Representatives, was on the appropriations. And many of you, if you've been with the agency for a long time, will remember the Department of Human Services. They put a rider on the budget. It was called Rider 37, that basically said, just for nursing facilities, that if you wanted to move from the institution to the community, that money that was in the nursing facility budget could be transferred to provide those services in the community. That state rider, and there's actually now even a state legislation on putting that into statute, preceded the federal money following the person. And when Governor Bush became President Bush, money following the person, President Bush doesn't get a lot of credit for the implementation of money following the person, but it was under his presidency that the first $1.75 billion. And why money following the person was so necessary, I take you back to the institutional bias, since it would take Congress statutorily to change that, and if they were resistant to do that, advocates had to find a way to get and keep people out of institutions. So MFP rebalancing demonstration, and it's technically still a demonstration, is to reduce reliance on institutional services, develop community long-term care opportunities, and enable people with disabilities of all ages to participate in their communities. And again, to use the jargon in the older community, that's aging in place. We are in the disability, we call it independent living. In the aging jargon, it's aging in place. But the goal is still, the same, to get and keep people out of institutions. And money following the person is just one method of funding right now. But I just want to make it clear, Olmsted does not rely on there being money. If an individual wants out, they're basically, there has to be a mechanism. And again, unfortunately, it would have to go to litigation to do that if the state, in fact, does not provide the adequate package. And as we all know, Texas is very conservative and frugal in terms of that. Next slide, please, Patty. This slide talks about, some of the stuff I talked about, established by the Deficit Reduction Act of 2005. There was a 5-year funding at beginning. Texas, like I said, was one of the first states to receive an MFP grant. It got extended in the Affordable Care Act under President Obama, and then 5-year extension of $2 billion. And then It was supposed to end in 2019, and so it was extended for 2 years and added 112 million. Right now, Texas still has MFP funding. Some of that is now being used for the relocation specialists, which LaCondria will talk about in terms of that. And to Texas's credit, they established a relocation program funding mostly through the independent living centers, but also in North Texas, it's the relocation specialist is in the area agency on aging. Next slide. Home and community-based services. I'll go quickly because you've heard this so much. One of the frustrations and things that, in all honesty, we still don't understand is that it's cheaper in the community than it is in the institution. You can see that in this slide, some statistics about how much cheaper it is. It's preferred by so many people to live in the community. The reason, like I said before, it is, I believe people still have the basic idea that if you have a significant medical or cognitive disability, it can only be treated in a nursing type facility. And we have seen over and over again that the identical person who is now in a nursing facility is being provided services in the community and at a cheaper level. Is it easy? Is the support package simple? No, and LaCondria will talk about some of the specifics about that. Next slide. Again, this just reiterates the issue of cost savings that can be done in Medicaid. And one thing that is now new, it's somewhat related to money following the person, but you will hear a lot about, and we think will be the future of home and community-based services, is what's called social determinants of care in Medicare. And so they're actually in managed care, Medicare managed care, there can be what's called social determinants, which basically is independent living services that we have talked in there. And that will enhance the ability to provide services because so many older people are on Medicare, some are dual eligible Medicare and Medicaid, so there will be a combination. And so we are fighting to make money following the person permanent for the Medicaid population, but we don't want people who are older and not on Medicaid not to have the services in the community to be able to thrive and live in the community. We are really in an exciting time. We just learned with COVID that having people in a box is not only is it not good for public health, it is not good public policy. And we are inching along and it's exciting, and we really are excited that the Ombudsman Program is joining because you can play a critical role in identifying and letting families and individuals know the options that are in the community. And I believe that's the last slide for MFP. Let's see the next. Oh, okay, I'm sorry. I probably went too quickly. Obviously, the next steps is, like I said, make MFP permanent. There's also legislation to make home and community-based services also the entitlement there. That's a piece of legislation that is now in Congress, and that issue that Nancy brought up about recruitment and retention of attendants, that also is in some of the infrastructure. So there are many exciting things. And like I said, Texas can be on the cutting edge of that, because if we philosophically, move that people should live in the community, we have an unbelievable ability with very limited funding, because we can't push the legislature to make funds, but we can, with the funds we do have, basically put together packages that would work. And so I just want to stop there and just really want to commend the Ombudsman Program for the potential to really play a really major part in getting and keeping people out of nursing facilities and other assisted living as well. Thank you.
I can just go over this really quickly. It's just, we want to divert and decrease the likelihood of institutionalization in the first place, and sort of everything Bob said. And I think now we go to LaKendria with the Houston Center of Independent Living. And you can, yeah, thanks.
Good morning. So with all this information that we received, thank goodness for the Olmstead decision. We're so grateful for the Money Follows the Person demonstration. Now that these things have been put in place, we still need to educate and let individuals know what is available to them. And that's exactly what the Houston Center for Independent Living does. As you see on this slide, we actually offer information and referrals. We continue to do peer support and individual and systems of advocacy. Also, we do independent living skills training and coordination of services. And what we do is we promote the full inclusion of these equal opportunities and participation of persons with disabilities in every aspect of community life. And with the coordination of those services, that's how we start and try to influence those individuals that are not wanting to be institutionalized by using those resources that we have with Money Follows the Person demonstration. Next slide, please. So here we are with My Home, My Choice. For record, HCIL has successfully relocated 2,081 individuals from nursing facilities that are now independently in the community. There are still approximately 172,284 disabled people on home and community-based services waitlist in the state of Texas. So just be known, Money Follows the Person demonstration actually covers more than just one type of transition services out of the nursing facility. Let it be understood that it depends on what is needed and the type of disability for these service waivers. So let's kind of zone in a little bit about what I do at Houston Center for Independent Living with relocation services. Can we go back and stay on this slide? So as a relocation services manager, I also have been a relocation specialist as well. That's how I began my part with Houston Center for Independent Living. And just to let you all know, anyone can start a referral for these services. Of course, we do aid on the support of Health and Human Services, but also the Ombudsman, the relocation specialist, the social worker, family, friends, anyone that picks up a flyer out of the street, that can start a referral. So what you do is you can always contact Houston Center for Independent Living just to give us word of mouth that, hey, I know someone who's wanted to get out of the nursing facility. And as an advocate, what we do is we research. Of course, we obtain consent and find out that these services are desired by that individual as well, and the support system that they will have in the community. Now, once we go through that referral process, of course, starting with Houston Center for Independent Living, we do have to include our providers, which is United Healthcare, Molina, depending on what county you're in, Superior, and also AmeriGroup as well. So it's a big group that actually works together, of course, in their own entity of the MCO, where the relocation specialists, the family, the nursing facility, and health and human services all conjoin together to make these services flow. As a relocation specialist, what my job duty is to, number one, be an advocate for those individuals that are in a nursing facility. Yes, we understand that our Medicaid model for those MCOs is important to ensure that they have the medical needs, but where does the happiness come from? That's what your relocation specialist does. The community, the support that will be at home, and also importantly, those that are also involved, such as ombudsmen. You all can play a part to understanding and helping what will make this person happy. So the relocation specialists, with the support of the community and those that are involved, we all come together and find a plan that fits the medical need of Medicaid. So once we all come together and we find a liable plan, services are put in place such as home health care, if there are individuals that need a little bit more support from the family. And also, it's also important that we pay attention to the environment of where this individual is going. So we like to make sure that there's a space where you can sleep, eat, and be comfortable. Now, once that has been determined, then of course, this is the exciting part of the process. We get to move those individuals out. So the funding that we have from Money Follows the Person demonstration, this is the important aspect that allows us to make these things happen. Again, we do ensure that those monies that go to the nursing facility follows you outside into the community. Whether you're going to a personal care home, assisted living, if you're going totally independent, or even with family and friends, you are entitled to those fundings because those are assisting you to continue the medical care that you need and to be successful in the community. Now, once we do find placement, of course, there are many different pockets of how Money Follows the Person demonstration is spread out. If you're going independent, we assist with things such as furniture. And then also we assist with food and clothing as well, too. It's basically to ensure that there's no lapse in services coming out of the nursing facility back into the community. So that's why it's important that we all play a part. We continue our advocacy and also help these individuals reach the ultimate desire for what they can achieve in the community. Next slide.
Okay, so we have developed a list of resources, community resources, that you all can refer to or reference after you obtain the information from the presentation. And some of these resources can assist you in finding housing for people you're transitioning. There's actually funding available in some of the programs for furniture, to buy furniture for people. Some of these, a couple of these resources are, one of the issues that we've heard is that people have difficulty obtaining copies of their different sorts of identification to assist them in transitioning. So we have resources listed for that as well. When transitioning out, there's services for helping people connect their utility services in their apartments when they move out. We have a list, as was mentioned earlier. There are relocation specialists around Texas that can assist, and the best source for obtaining their information in the different areas is by contacting the Centers for Independent Living, which there is also a list of all the Centers for Independent Living on this resource list. Another resource is the Area Agency on Aging. They also assist with different aspects of transitioning and is also listed here. Any additional information on some of the resources available to help transition people out of institutions and into the community is listed in this and 2 more slides after this. So we can continue with the next slides, please. Okay. Again, these are some of the resources available, and they'll be made available to you all once you obtain the PowerPoint presentation. Thank you.
we'll save those questions for our panel, but I've moved forward to the contact information. We've got about 10 minutes. Y'all did an amazing job covering so much so fast. Would you like to continue with your addendum content for the next 10 minutes, or should we break a little early and then start the panel a little early?
Bob, what do you think? Should we have a break or go over some of the other stuff?
I think why don't we take a break, and then we can have the questions and answers extended, because I think the real meat of this is to find out what you all who are watching want to know. I really just want to emphasize what Josue just said about the resources that's there, and adapt. The information there is also can lead you to information in the various areas. So I think it just takes a quick break and then go back to the panel.
Yep, so Patty said it right. So let's take a 10-minute break, and we'll actually start right at 11. So we'll still be able to hear and see microphones and video cameras that are on. So put yourself on mute, turn your camera off if you like, and answer and type in those questions for the panel. So we really want to hear from Ombudsman what you've got in your on your minds about relocation services and transition to the communities. So stay in this meeting link. Don't log out, but just come back in 10 minutes and feel free to start typing in your questions. See you soon. All right, everybody, welcome back. If our panel wants to snap their cameras and their microphones back on, if you've got access to the chat, you'll see we've got some great questions coming in. So I'll let everybody come back in and we'll get started with some questions. All right, I'm just going to start at the top of the list. For the panel, what is the answer for housing shortages for relocation? And I'll add to this and just say that I'm sure many ombudsmen are thinking one of the first things we hear is, well, they don't have a house in the community or they don't have anywhere to go. So if you could speak to that. Hi, Stephanie. That would be awesome.
Sure. I'm Stephanie Thomas, and there is a shortage of accessible, affordable housing in most communities in Texas. However, it's not a complete zilch. There is housing out there, and there is assistance from the state and from some local housing authorities on this issue. There's the 811 program, which is designed to help people getting out, and it gives of them vouchers to live in, and well, not vouchers, but subsidized units. And then there are vouchers available also. These would be available through your housing authority, or through if you're in a smaller community, through the Texas Department of Housing and Community Affairs. But I would recommend that you work with your relocation specialist on this, because that's part of what they do, is to help people find that housing. There's also a website called Go Section 8, and it lists places that take Section 8. It also lists places that don't take Section 8, so that you can, and how much they cost and all those things. So you can look for affordable housing in your area through that website. Also, some communities and the state Texas Department of Housing and Community Affairs have started creating lists of subsidized housing, because very often it's hard to get a voucher. If you can't get one through the 811 program or another local relocation program, you will find that it's very hard to get a Section 8 voucher, because there's a long waiting list, and different housing authorities have different methods for signing people up for that, and usually there's windows of opportunity in that regard. So look for subsidized housing as well. Stupidly, housing organizations do not list these different things together. They'll have their Section 8 program, and then very often the affordable housing, subsidized housing programs are listed separately, and they need to be accessed separately. And that can, I mean, it's in the same agency, but they don't like cross-reference. They don't say, well, we don't have any Section 8 vouchers, but here, try this. Here are some units that have, here are some housing complexes that have units that are subsidized and are therefore cheaper. So, you know, you have to kind of be a little bit of a terrier to find, but once you get used to it, it's not that hard. And that's why I think the relocation people can be very helpful to you, because they've done that before, and they can help ferret out the opportunities that are there. And the main thing that I think is very helpful in this regard is persistence, because if you just ask once or twice, you know, likely you're not going to get a very good answer. But if you just keep at it and just realize it's going to be a bit of a push to do it, that's how we found housing for most people that we found it for, is just being persistent and being dogged and hanging in there. And there are opportunities for people to get subsidized housing. So those are all, you know, ways that you can address that problem, because it is a big problem. And I would like to say about housing, it is a very critical component of the whole thing, because you know, most places you can leave a nursing home to go to the street, but I mean, that's not a very good opportunity for anybody. And you're not going to get attendant services on the street, and you're not going to get a lot of other supports that you might need. So therefore, you know, housing is a critical component in the whole thing. And it's something that I hope that we all will push for and advocate for locally in our own home communities and at the state level. I'm sure you have plenty to do already, but here's one more thing to put on your plate.
Thanks, Stephanie. Oh, go ahead, Lydia.
I just wanted to add one thing to that, is if we diverted people from being institutionalized in the first place, for instance, caseworkers at hospitals, if they didn't, you know, if the default wasn't shuffling people off to institutions, many people wouldn't lose their homes to begin with. And I find that happens to so many residents is, you know, they break a hip, they're told they're going to receive rehabilitation, so they think it's temporary. Meanwhile, you know, either they lose their housing, their apartment, or, you know, their kids move in or sell their homes. So, you know, a lot of this has to do with, you know, diverting, you know, people from institutions in the first place. And I also wanted to stress how much money the nursing home industry receives from HUD, you know, and so really that funding should, I mean, I don't think we should subsidize their cost of doing business. That money should be going to disabled people to honor the Olmstead decision and the American with Disabilities Act. So,
you know, one other area that, and I think the Ombudsman can help, and COVID has brought this to light. Many families who at the time did not think they could provide services in their home to assist people. Basically, when COVID happened, thought, well, did I make a mistake? And we think maybe because there is a housing shortage, and it's really the major, every study of MFP has shown lack of housing as being one of the biggest issues. But we think there should be an HHSC, and I think the Ombudsman Program within HHSC, that every family should be reinformed of the MFP program, because maybe they will at this time with COVID reevaluate and actually have somebody move back into the home. We had one individual we worked with the family, and at the time they did not think they could provide services, but when COVID happened, they changed their mind, and the individual got out of an institution. So that was, you know, something I think y'all could maybe investigate in contacting the parents. And we've been trying to push HHSC to send out about the relocation specialist to every family and individual so they could do that. And then the other option that wasn't mentioned is that many area agencies on aging have housing navigators, I believe funded through the Title III Older Americans Act. And so I'm not knowledgeable on exactly which ones, but I know that program, it's separate from the relocation, but they have housing navigators. So it's a fragmented system, but like Stephanie said, you got to be persistent.
And just a clarification question, is the 811 program available statewide?
No, it's only in certain areas, and maybe it was where the, what's that? Yeah, they're mostly urban areas, so you want to check if you can get it in your area. It's a good question.
Thank you.
Yes,
And yeah,
I'm sorry, I want to add on to that. You definitely want to check for the area. And of course, we've had some closures of lists on the 811 for some certain counties. So it's important that you do visit the HHSC website to find that link forwarding to what counties are open currently.
thanks everybody. And I do, from the ombudsman perspective, I want to underline and highlight something that I've heard Bob say, and I think others have said, is that, you know, with this information, we hope that ombudsman can feel empowered to educate people about their options and to be a resource to moving out into the community. So I appreciate that for sure. Next question here. I was going to try and group these together, but I think that's going to be too difficult, so I'm just going to go down the list. Do you all have a good resource for folks that need an ID or social security card or a birth certificate? What would you recommend?
I can take this question because this is a lot with relocation services for those that are interested in independent living. Of course, it's understood those that are institutionalized, those records have been misplaced or somehow destroyed or taken by family members, you know, unsuspectedly when needed. So one resource, of course, things have changed because of COVID, but being post-COVID, these are some things that you want to ask or at least try to research if anything has changed. Those individuals that are institutionalized and needing an ID, there is a program with your local state of department services where they can come out to the nursing facility and actually assist those individuals to getting those IDs restored. They will come out, you make an appointment, you have to put in a request, and of course, again, researching what is happening post-COVID, they will reach out to you or the nursing facility and set this appointment so these things can be taken care of. Now, when it comes to a social security card and birth certificate, it's a little bit of a straddle. To get a social security card, you got to have your birth certificate. To get a birth certificate, you got to have your social security card. For those individuals that do not have any identifying records, there are some alternatives. I cannot go down the list. I do have those resources as far as them being updated. Yes, they do need to, but things such as shot records, baptism certificates, these are good documentations that are considered valid in order to help support those individuals that are trying to recover those things. Those that do not live in the state or came from another region, it's important for you to reach out to vital statistics, county hospitals where you were born, to find some type of determining factor to get those things. And of course, you know, once you have one, that's a ticket to get the others.
I just wanted to add something to that, as I've come across this very thing with residents, and you know, ideally you would think that the nursing home staff, the social worker would do this, but from my experience, that's not been the case. They won't take the time. So residents have asked me to help. And so, like with the Social Security office or veterans benefits, you know, they didn't have access to a phone. So I just let them use my phone, and I help them. And they have to be there and talk to the Social Security office. But, you know, I've helped them order, I can't remember the form, but it was something from the VA because they got kicked off of their benefits. So, I mean, we ordered VA stuff, but Social Security. I even, like with veterans, you can contact, there's so many, there are myriad veterans organizations out there that will assist with this type of thing if, you know, if the VA is, you know, happens to be dysfunctional that week. So, and there was one time where this was, the person had back payment on their Social Security, and so the nursing home was going to, they told me, you know, drop them off. They told me this at Salvation Army. And so I called my congressman to help him. I'm like, hey, you know, here's a veteran and I don't want him on the streets. You know, could you help me with this? And they did. So, I mean, it just takes persistence.
I just want to add, you know, it's probably overused, but it takes a village. What we have learned, and LaCandria has been right there in the community doing this, is that it takes not only a length of time, but it really takes a coordination. But I think volunteer ombudsman and staff can really play that integral part, because, you know, without the initial contact, you know, LaCandria can't do anything if they don't know the individual. And many individuals, you know, are thinking about it, but are frightened, and they need to know that there's support. And my experience, I've not actually transitioned physically somebody, but I've known many people who have, is that, you know, you have to build the family, the individual, and it takes time. So that, but I think the ombudsman is, like I said, if you don't know the person wants out, or even thinking about it, we can't start even helping.
I'm upfront with people about that, you know, because I don't want them to become demoralized. So I let them know up front that, you know, this is a process. And I usually say, you know, it will take at least 6 months. I'm just upfront and I'm honest about what's going on with them, so they know what to expect.
That's great advice, Lydia. And I'm sure there were a lot of people nodding along in support when you mentioned that the ombudsman doesn't feel like the residents are getting the support they need from the social services worker at the facility, whether that's the social worker, or oftentimes there's an open position for a social worker. So I think the ways that you described, of course, with resident consent, we can really be you know, flexible and creative in trying to find solutions to help the resident based on what they want in their direction. And this may come up, and we can talk about this in a little bit, but the ombudsman isn't there to tell a resident that they, you know, won't qualify to leave a facility or they won't be able to make it on their own in their community. We're there to show them how they can reach their goals, and how they can get to the places that they want to be at. So we'll, I'm sure, hear more examples. Go ahead, Tiffany.
I just wanted to say that along that same line, very often people become very demoralized going into an institutional setting, and they feel that then there's something wrong with them and they're not able to do things that they were able to do before, and they may not know how to do things that they were able to do before. And so I think a very important part of this whole thing too is to be encouraging to people. And I'm not saying, you know, say, oh yeah, you'll walk again or whatever, you know, your speech is going to come back completely normal, you know, don't, I'm not talking about promising things that, you know, can't happen, but at the same time, to be supportive and to realize that so that you know that for every person in a nursing home, there is basically a functional twin living in the community. And so it's a process of finding the supports and learning the skills and so forth to be able to make it happen. And that your willingness to encourage that is vital, because a lot of people really they just lose faith in themselves, and you can restore that in this way. So
go
ahead.
I was just going to say we had done a video, and one gentleman said something which is, he said, when I got into a nursing home, they acted like they owned me. And, the thing that people need to recognize is that also, because it's a process, maybe they should be able to go to a AAA event outside. Not that they're getting out, but they can interact with other people who maybe have similar disabilities living in the community. We've seen that with some younger people who are in institutions who we've had come to an ADAPT meeting, interact. They're not ready to make the leap, to get out there, whether they don't have the housing or the attendance services, but they interact in a social sense because, again, you're not a prisoner, though the staff acts like they own you. I mean, you have the right to get up, take paratransit or main line and go to the mall, but they don't do that. And I think it's very ageist to think only young people would do that. I think it's a mindset that the individuals are not just have to stay in that place and wait until something opens up, nirvana, but that there's still community activity, and whether it's church, synagogue, mosque, whatever. So.
Yeah, I think it's I like the concept of a functional twin. I hadn't heard that before, so that really resonates with me, and I think it speaks a lot to just the institutional bias of our country and beyond, that when we imagine somebody who, is disabled or is older or both, that maybe we think of them not being out in the community and we assume that they're going to be in a facility, when we really need more exposure to folks that are living their lives out in the community, because that can show us all that, that's their preference and that's a possibility. This actually leads into, I think, one of the questions that Lydia, you had posed that I think would be helpful to talk about now is, we hear often that, oh, so-and-so can't leave because they need 24-hour assistance. Can you all speak to what assistance is available for folks in the community that do need that 24-hour care?
First I want to address a few things, and that's sort of the, paternalizing medical model view of disability that, we need to be socially removed and segregated to keep us safe. But, over 182,000 people, disabled people, died of COVID-19 during the pandemic in substandard institutions. 191,000 institutional staff died because they weren't provided PPE and basic training. And I just want to say that, it's well documented that this has been a predatory industry. And here's some government statistics. So more than 1 out of every 3 nursing homes have misreported their data. A study by the United States Inspector General Office found that 20% of high-risk diagnoses requiring emergency room treatment resulted from abuse and neglect. And these included head injuries, traumatic brain injuries, facial and nasal fractures, lacerations and contusions, bodily injuries, for example, numerous fractures of femur and vertebrae and dislocated shoulders, and poisoning. Nursing homes reported only 16% of these cases of potential abuse or neglect to state agencies. In turn, the state survey agencies whose job it was to investigate potential abuse or neglect reported less than 3%. Nursing homes failed to report 40% of the falls that resulted in the hospitalization of residents. 75% of nursing homes didn't have enough registered nurses on staff. 82% of nursing homes, that's 13,000, had serious infection control deficiencies. I want to point out also that over 300,000 nursing home residents are inappropriately given dangerous antipsychotics, even though most have no psychosis. And the citations for misuse of antipsychotics increased 200% between 2015 and 2017. So this costs, the misuse of antipsychotics costs taxpayers $363 million annually. And falls and other things resulting from the misuse of that cost taxpayers $50 billion. So the idea that, you know, we have to segregate people and socially remove them to keep them safe is, that's just, it's based on, you know, a false narrative. For instance, in my experience as an ombudsman, there have been like 20 residents for one CNA, and some of these have been significantly disabled people. So it's not like anybody in a nursing home is getting 24 hours of care a day.
I was going to add, number one, people don't, a lot of people think they need 24, and like Lydia said, they don't get 24 hours. But it speaks to what the relocation and what the ombudsman and the social is, that you build a package so that it may be the Medicaid waiver package, Star Plus, the Area Agency on Aging, and then you add informal care, any family and friends, to pull together a package. Because yes, it is, you know, people are frightened, and that's that transition that LaCondria talked about in terms of building that, and why it takes so long. Because I think every one of us has heard when they've gone and spoken to somebody that I'm not getting out because I need 24 hours. Well, we have high-level quadriplegics living at home all by themselves. That's not the model for everybody. I don't want to use, you know, just, you know, a few individuals. But again, that's why, you know, some people, family may be assisted living. It's not our favorite, but it may be where it has a little better protection, where individuals do want maybe a roommate situation, you know, type of thing, pair up with the attendant. They're really, it's, again, I think Lydia said it so well. You know, if you start from you can't, then you don't think what you can. And so we know so few people that actually need 24 hours. I mean, again, maybe people on ventilators, people that, you know, have some significant need. But if that's what they think, that's the evolution, the 6 months that I think we'll talk about.
Thanks, Bob.
That's not just us saying that. I mean, there are experts like Charlene Harrington and Bill Thomas and so many others who are, you know, saying exactly what we're saying. And what I'm finding is there's so many residents that their impairments aren't even as severe as mine. There's one man who is practically, he would do laps around the nursing home every day with his walker. I mean, it's, yeah, so.
Everybody, it's based on your circumstances.
So I'm hearing some background noise. That's what I was trying to interrupt. I'm going to mute all, so participant or panelists know that you'll have to unmute yourself again. 1 second. Thank you so much for the audio back and forth. We want to make sure we can hear everybody. The next question, I think, is it doesn't specify what type of assessment, but I can think of a few. The question is, If the resident fails the assessment, can they file an appeal? And I'm wondering if y'all can talk about what to do if a facility says they aren't able, what to do if a managed care organization says they aren't able, and maybe even, anything else you can think of that might be somebody assessing the resident who gives them a denial.
I do know that all Medicaid, if they're on Medicaid, HHSC has a Medicaid appeal process. All Medicaid services in the community, managed care, fee-for-service, Title 20, all those programs have an appeal process. Then the other is working with the local advocacy community, whether it be the Independent Living Center, the Area Agency on Aging, or if it's a person with a developmental disability in there. So there's some advocacy there. And then there is the litigation, a complaint that can be done through Olmstead complaint if the individual. Again, one of the reasons we talk about the advocacy group, because when you're in a nursing home, it's intimidating, and the person needs to know there's some support out there, that they're not going to complain and then be at the mercy. And I'm not saying that they're going to do something to injure the person, but it's a very controlling situation. Every one of you listening has been in the hospital, and you know what lack of control is when you hit the call button and nobody comes. Well, think of it in a nursing home, and you're going to complain about the people who are providing you. And think of it, you can't get out of bed unless they come and get you out of bed. You could lie there, you're in the tub, and you're going to turn into a prune if you piss off your attendant. So again, you have to take the mindset of what, they're not the hellholes of Calcutta like they used to be. They've gotten better, but it is still a very intimidating place. And like I said before, they act like they own you. They just do. And they do it in a caring way. That's what's so scary about it. It's not like they're, wrenching their hands and, drooling and, all that stuff. We're going to take care of you. No, it's more, we're going to take care of you, that type of thing. So that's why we talk about getting with, an independent living center, an area agency on aging, or other support group to be able to build that you're not alone.
This is Nancy. I just wanted to interrupt because I've been sitting still too long. I wanted to say that part of the evaluation process, or the needs assessment, if you've ever seen the form, trying to explain it to a person who has never had an assessment done is hard. And so they're going to need to be educated on it so that they understand what they're being asked. That's what we're finding out in a lot of situations. People are not passing these assessments because they have no idea what that question meant. So that's just some of the kind of things that we look at when we try not to go, to the Supreme Court all the time. But if we can figure out these things beforehand, it's a lot easier.
Yes, and I want to interject as well. As far as when it comes to assessment, that I agree with Nancy. That's really the only time when an assessment is failed. The resident is not aware or has been prompted to let them know that someone is actually coming out to ask them about relocation services. You got to understand the community support is important. If the social worker is advocating, knowing that this person wants to leave the nursing facility, there should be no surprise on their part. You got to understand these people are afraid. They are unknowing of some of these individuals. And of course, they've all been prompted, oh, don't talk to anyone you're not sure of, don't sign any documentations, or speak with someone that says that you want to leave, because they're always fearful about their benefits. It took them quite a while to get where they are, even though it may not be the ideal situation, but it's a roof over their head. So when we say failed assessments, a lot of times it's either actual denial because of the ignorance of what's going on, or because of the fact there's actually, not enough community support available. And that's, no one's trying to enforce the medical model, but that is the conversation Medicaid will have if there's not enough community individuals to support this individual back to the 24-hour care. They can only provide you 8 hours a day. That other remaining of the day that you don't have someone to come out to the home, that's where the community needs to come in. And if you can't give them a name, a phone number, and an address to who this support is, then that's why it doesn't become a successful relocation. And let's just let it be known, I have been doing this for 5 years. I have several relationships with individuals in a nursing facility. They'll call me by my first name because of the many times that I've worked with them to get them out of the nursing facility. This isn't just you fail one time and we never come see you again. I have social workers that are advocating and saying, hey, you know what, 6 months has been down the line. Mr. XYZ, he's actually had an improvement in his health. Can we try this again? And if you continue that conversation of wanting to get out and you're doing or asking for the help to better your health, yes, there are times where I see you 4 and 5 times, but number 6 may be the charm.
I would like to also point out that the hours a person gets of care vary from state to state. And I think part of advocacy is looking, beyond a very atomistic frame and advocating for, disability rights, calling your legislators, saying, look, care attendants in Texas, they need to earn more than a pittance of a wage. We need more hours. So I think the thing is diverting that money, from an industry that's proven itself predatory to, home and community-based services that honor the civil rights and the dignity of people with disabilities. So, I mean, we have a lot of problems in this state, and I think, it's going to require all of us to advocate for change. And I think, that is also a part of our ombudsman advocacy, to advocate for, the residents and what they want and what's in their best interest.
Thanks, y'all. We've got a couple of related questions. So before we move from this topic, couple ombudsmen have commented that they see if a doctor doesn't agree with the transition, then the process just stops. Can y'all speak to what to do in that situation?
Well, doctors actually know very little about how disabled people live their lives in the community. And so I would just say, find a friendlier doctor, or, don't rely on the nursing home doctor. Nursing homes don't own you. You can leave at any time. It is not like you have to stay there, but you do want to have the supports and so forth. So it's, it's good to get that worked out, but nobody can be denied and then locked in. That's not, people who are deemed incompetent, I suppose, but other than that, there's not they don't have a lock on you, even though they do act like that sometimes. But there are, I think the testimony of other people given strongly is another way to fight that battle. If a therapist of some kind, really thinks that a person, and can give some evidence, that can all help to counterbalance the doctor saying, oh, no, this isn't going to work. And finding a doctor outside of the nursing home who can also give their assessment is another route to go, because they're not going to be in the pocket of the nursing home.
The other avenue, because the doctor plays such an integral role in our lives, and you know, even though I owe my life as a quadriplegic to the medical, like Stephanie said, they have not one iota about our lives in the community. They only see us in our medical need. But that's where potential litigation or, you know, Disability Rights Texas is available for, you know, for people who are willing to take that step. But once again, the individual has to feel like there's somebody behind them, you know, that whether it's their family, or if they don't have a family that's supportive, a person like LaCondria or an area agency on aging. It's a scary thing, and you know, in almost every avenue, the doctor does have an undue authority, and like Steph said, they're the least knowledgeable of our lives in the community. They know our medical condition, but they're learning, but they're not there yet about people with significant disabilities, cognitive as well as physical.
Great. Trying to get some pick questions that maybe are a little unrelated now to what we've already talked about. Can you talk about what happens if somebody tries to transition on MFP, but it doesn't work? Are they able to try again, or is it a one-time deal?
I can answer this. Again, like I said, I've worked with people probably my whole duration and still trying to get them out the nursing facility. For someone who does successfully relocate, the only one-time benefit are those things that are provided to them for that transition. When I spoke about the food and clothing, and of course you all can view this information from the PowerPoint that was provided about relocation services. That food and clothing, and then those that are going totally independent using TOS benefits, which is provided by the MCO, those are the one-time benefits that are available. If something happens and you have to become institutionalized again, MFP is still available to you. It's just that some of those monetary tangible items that were bought or done can not be done again. And that's the only part about it. So remember, when you're working with your relocation specialist, they are an abundance of information for you. Please, as we're going through the meeting chat, these stereotypes that are being portrayed out here, you need to talk to who's in your region. Talk to your relocation specialist. Reach out to these SEALs. I helped more than one individual move out more than one time before. So just because those resources of the food and clothing have already been used, there's still a pantry that's available that I have connections to that I can provide to you. There's still resources of churches giving away furniture items that I can still find for you to do that again. It's not I fall and I can't get up. We will help you get up. Just call us.
Yeah, and I just want to reiterate that whether the actual support service, Star Plus, community attendance services, family care, all those programs are still available. You know, again, those are not like time limited. I mean, they're not linked to MFP. You know, if you're eligible for those HHSC funded programs, whether through managed care or fee for service, you are eligible. The support services, which we think are integral, but not necessarily, like LaCondria said, the pantry is just a local volunteer type of thing. So if you have individuals that want to help you and get those same services, again, you're not a prisoner. You're always able to access what you are eligible for in the community. It's just a matter of, can you get the supports?
Yeah, speaking of myths, I just want to quickly address one concept that we'll actually talk more about in our residents' rights presentation tomorrow, is this myth about liability. So liability is never a reason to restrict somebody's rights. So I'll just say that blanket. So if it's the facility, if it's the managed care organization, whomever who says we can't let them go out in the community because then we'll be held liable if something happens to them, that's not gonna cut it. A question about a topic I know you all are very familiar with, interest lists and diversion slots. So if somebody either loses their Star Plus waiver in the community or was never on one, what are the current options in Texas for someone to avoid having to go into a nursing home and then to qualify for MFP?
If you're on Star Plus because you're Medicaid eligible, and you're SSI eligible, there's no waiting list at all. It's just those that are up to 300% of SSI, and then the developmental income at 3 times SSI, which is about $2,200 a month. Those are eligible. There's a waiting list there, and then all the developmental disability waivers have long waiting lists in terms of that. So if you're getting out and you're on one of the DD waivers, I don't think, you might then end up at the back of the line, depending on that. On Star Plus, if you're SSI, you're eligible automatically. You're entitled to the support services. And if you can make it on, and there's 80,000 people on this program in Texas. It's called the Community Attendance Services. The vast majority of those people are on Medicare, but they can get basic attendance services. They don't get the whole package, but they can get basic attendance services if their income is up to 3 times SSI, which is about $2,200. It's really it's a Medicaid funded program for people who don't have a Medicaid card. And like I say, in Texas, in the community, there's 80,000 people or so on that. Most of those are older people there, but that's an exciting, program that's out there. So, again, it's just a matter of getting to the right resource in the local community. But the community attendance services is statewide.
And I think all of this goes back to ending the Medicaid institutional bias, with the default with taxpayer funds not going to socially removed disabled people, but to fund essentially what amounts to our civil rights. And there's so many groups working on this right now. I've been working on it with healthcare economists and the National Great Panthers, ADAPT. I know there's several bills in Congress right now promoting home and community-based services too. There's the Better Care Act. If I'm
Medicare, Better Jobs, Medicare,
yeah,
Better.
Yeah, and that's trying to support disabled people in their communities with, I think it's $400 billion. And so I think we have to look at our lives beyond what's cost effective and convenient for non-disabled society, because when it comes to other groups, we don't curtail their civil rights because we've decided that, we can't afford it. Just look at the tax breaks people get, and the fact that the nursing home industry just during COVID was given over $20 billion. And then they were still saying, we don't have enough money for PPE and testing. And there are healthcare economists and people in Congress right now asking them, well, where did the money go? and they want more money still. So I think we have to look, beyond, whenever we just reduce a certain group's rights to, cost, I think there's a problem with that.
Can I just go back to something you said about risk? Because that comes up all the time. We have a thing that we say, the dignity of risk, in terms of that. And I was on a nurse delegation task force from the nurses, and I had the reputation that I wanted attendants to be able to do brain surgery with a spoon, but the bottom line is that we have.
Not true.
That's not true, right? Thank you. But the bottom line is that there is things that can be delegated by a nurse to a personal attendant that could lower the cost in the community and be done safely. And there's a whole range of what used to be called medical tasks that are being done by an attendant, delegated by a nurse, and done safely. So, and through that process, we heard all in the beginning about how risky it was and things. So it's real. I cannot tell you, the medical community says that all the time, but that is where, working and advocating to try to push back against that medical model that Lydia so well described.
Thanks. We've got about 5 minutes. So I bet we can get through. I think I see 3 more questions here. And if we don't get to a question, we'll definitely can help respond in writing. Is there an option for community attendants to stay with someone overnight?
Yes, it actually is. Going back to as much as a live-in aid, those individuals that are needing maybe 24-hour care and they're going into some type of independent housing, it should be understood that there are placement, or there are able to make reasonable accommodations for those attendees to live in or stay overnight. And remember, again, this comes from community support. If that agency is having those type of attendees being able to do that, it doesn't always have to be someone. That could be a family or a friend. And also with those, back to the housing vouchers, those reasonable accommodations, that can be the reason why someone moving out of a nursing facility needs a 2-bedroom apartment rather than a 1-bedroom, to make an accommodation for that live-in attendee. So it just depends on how you work your cards and what situation you're put in.
And this is Kathy, and I'd like to add to what Kendria was saying. It's so important to be able to depend on informal support. I know there was a gentleman out in Brownsville, and we had to work with the managed care organization because they were saying he can't stay at home anymore. And we says, well, wait a minute. And so depending upon what home and community-based service program that individual is on, sometimes they have extra hours, and they can figure out how to, I don't want to say chop up their program, but decide, okay, I don't need this service, but I need this. So can we put it over here for, hours, or also, like I was saying earlier, informal support is really important. Get to know people around you, and not everybody has that. Not everybody has family members. And so it's just, there is a way. And also sometimes it's just a learning curve for that individual that is coming out into the community. They may think they need 24-hour care, but they may not need it. And it's about educating them and empowering them to know that they can survive without, that 24-hour care also.
If I could interrupt you, I just want to say I usually live in attendant services for myself, but it's not 24/7. I mean, they have a life, and if I wanted 24/7, I could go into a nursing home. But Living on my own for 43 years, I've been able to take care of my attendant care services, and also as I'm aging, I'm finding, I'm needing a little extra here and there. But, and like Kathy mentioned, the informal supports. I've got neighbors, I've got friends that would pop over in a second to help out.
Thanks, Al. I'm going to squeeze in one more question, and then we'll have to get for next time. What happens if somebody, two similar questions. Can somebody who is not on Medicaid use relocation services? Second part is if somebody is on Medicaid, do they have to use relocation services?
Oh my goodness, if you have the benefit, why wouldn't you want to use it? That's like eating potatoes without the meat or the gravy. Why? Why? But yeah, you can. It's a package deal though. Like you said, I mean, if you go out with just money follows a person, just with your MCO, where's your advocacy? Who's gonna say no? They don't want to go to an assisted living that has 75 people. They want to go somewhere that only has 40. Who's gonna do that for you besides you? Who's going to stand up and do those things and do the actual research for you or your family, provide those listings? This is a help to you. But I mean, there are some families that feel like they can do things or more appropriately or a little bit more fast paced than what we can do, but it's a group effort. The more we talk to each other, the better the services and the outcome can be. And again, like Kathy had mentioned earlier, you don't know that there are options for you sometimes where you can kind of switch up and interchange and get something different versus something that they're telling you that you need to have. That's what your relocation specialist is for. So I would encourage you to always use that person, but it is a course of a choice if you don't decide to. But if you do not use your relocation specialist, you will not get your food and your clothing. And if you are over budget on those toss items, the relocation will not be able to come in with a shovel with an extra couple of $100 to say, hey, they told you no to that blender. I got a couple of dollars for it. You won't have that.
Well, that is a great note to end it on. Just a big promotion to use your relocation services resource. Everyone, we can't say thank you enough. I'm sorry to end so abruptly. Ombudsman on the line. You'll actually log out of this, go to your agenda, log into the next event. But thank you so much, everybody.
Well, free our people.
Free our people.